Hello, everybody. This is Deborah Dunn, GAPNA National President, and this is our series Facing Forward. Today, we're going to be talking with Ron Ordona, and as you know, in my prior interview, I talked about us looking toward our GAPNA experts to hear about how they're managing their patients through the COVID crisis. So I'm really glad to have all of you with us here again on this second interview. So as we face forward into the storm of COVID, we're all trying to give the very best care we can. And this series is really looking at our GAPNA experts to help us with some tips and some ways that they're coping, lessons learned. And I hope that you will find that very helpful and interesting. Today we're speaking with Ron, and he's a GAPNA member and expert in home-based primary care as well as residential care of older adults. I want to tell you a little bit about Ron and welcome Ron to our interview today. Dr. Ron is a DNP. He's a family nurse practitioner. He has a private practice that focuses on home-based primary care for the homebound older adult, working out of Sacramento, Northern California area. Ron is board certified in both family practice and gerontologic nursing. He's a graduate of Boise State University, and he also teaches. He's a volunteer educator at UC Davis Betty Irene Moore School of Nursing. Ron did some really interesting work in his doctoral studies. He looked at quality improvement on transitional care, medical house calls, and looked at reducing the unplanned 30-day readmission rate back to ER or hospital of patients who were discharged from hospital, and in fact found that home calls were able to reduce that 30-day readmission rate and also had a significant reduction in polypharmacy. So that was really great work, and Ron will be able to tell us how he uses that work today in his home-based primary care. Ron also consults and works out of residential care facilities for the elderly and assisted living. He also works in Alzheimer units, memory care units with older adults. In his GAPNA role, he is an immediate past chair of our House Calls Special Interest Group. He is the president of the Northern California chapter of GAPNA. He's very involved in policy and advocacy interests and work, and has recently received our Health Affairs Committee Scholarship for the 2020 AANP Health Policy Conference in Washington, D.C. So I think we're going to have a great conversation here today about from practice to policy with Ron. Welcome, Ron.
Thank you. It's great to be here.
I want to start off by asking you if you could share with us how the COVID healthcare crisis has impacted your home care practice.
So the current pandemic has really put a big dent on home care, home-based primary care especially. For one thing, we are not able to see our older adult patients in their homes. Particularly, or really just to protect them. We don't want to inadvertently bring anything to them because they're more susceptible, vulnerable compared to us. So where before we would go on a house call visit, sometimes on a regular visit where a senior and older adult may not be sick, we'd come in and visit. So in that sense, that it provides them some social interactions as well. So that all that has stopped. So we've been doing telehealth visits, and the telehealth visits we do now are, I would say 90% of them, older adults, their caregivers or their families who are concerned about what's going on, being out there on their own, either in their own homes or in facilities such as assisted living or the board and care homes. So those visits have stopped, and so it's compounding the social isolation that our older adults feel. It's been there even before this pandemic, and now it's really just making that worse. I believe.
Right, right. And I know that many families are setting themselves up on maybe weekly porch visits or things of that nature. I know that we've relied on a lot of technology to help us out. Do your seniors in the home have much in the way of technology that they're using, or is it mostly cell phone, Ron? Do they use their computer?
So it's case to case. I would say an 80-20% split. Some 80% really do know how to use technology. They have smartphones where we can do telehealth visits using their phone. I'd say 20% that either does not have the smartphone, they would have flip phones or the old house phone.
Mm-hmm.
Some, of course, they have some underlying dementia. They're not able to push a button or do anything like that. So those are the challenging cases where we have to either get either a family member or a caregiver to be with them when we do the telehealth visits.
Oh yeah, yeah.
Yeah.
No, that's great. I'm really pleasantly shocked that 80% have some sort of computer or tablet or something that they can access telehealth.
Hmm.
I think this is going to change the way that we're doing our visits and maybe some of the regulation around telehealth to allow us to do more intervention with telehealth and supplement maybe our home-based visits. I don't know. What do you think?
I agree. So the relaxation of the rules for telehealth visits has really allowed us to help care for this homebound older adults easier and more efficiently, both on both sides. On our side, where we used to have to drive to a older adults or a patient's home, which will take time. So we are limited in our daily visits. Where now we can see somebody who calls in and says, "I need to be seen right away," or at least the following day. That has allowed us to do that with telehealth technology. And we're hoping, especially with home-based primary care, that it will continue. It's just an additional tool that we can use to care for our homebound older adults.
Yeah, I love that. That's a silver lining in all of the crisis, pushing us and then pushing regulators and insurers, to
Right.
allow for some of these things. And that's what we're usually um, bound by, and the reason why we haven't been able to engage in it as fully um, as we have in the past.
Mhm.
What would you say your top concern is for your homebound seniors during this healthcare crisis? Is there one that you comes to mind?
So number one on my list is a social isolation, as I
Mm-hmm,
mentioned
mm-hmm,
earlier.
mm-hmm.
Um, we score our older adult patients on isolation, and there's a range 1 to 4, 4 being there's no problem, and 0 or 1 being there's a problem with social isolation. Most of our patients are scoring between 0 to 1, and 2 would be our highest, which means they are really high risk for social isolation. So this is my biggest concern with what's going on, because it's compounding that social isolation.
Mm-hmm.
Families are not able to visit. They can visit FaceTime, but it's so different with human touch and the contact with somebody there physically with you. Um,
Right.
that's my biggest concern. My second biggest concern, of course, and it works with the social isolation, is they are very vulnerable to anything, not just the coronavirus,
Yeah,
and especially.
exacerbations of
Mhm.
their own chronic conditions, right?
Right. Yeah. So that's the second uh, concern that I would have for this particular group of patients.
Yeah. And in what we've learned, of course, about social isolation is it can confer the kind of risk of other things, you
Mhm.
know, physical inactivity, smoking. It's a big risk factor impacting health, right? So
Right.
I think it's great that you're focused on that for
Because
sure.
I had a patient this week who her husband comes to visit almost every day. She lives in an assisted living facility, But so now, of course, because of the COVID-19, there's no visitation. So we are seeing some depression. She's not eating about 50%, and she's diabetic. So we've been seeing hypoglycemia recently, though we had to adjust diabetes medication. And then there's also the lowering of the blood pressure. Her blood pressure starts to go down because of just not eating. So it's a problem.
Yeah, yeah, yeah. And we have some, pre-existing anxiety, depression, certainly in persons with dementia.
Mhm.
So not being able to see your husband, your significant other, whoever you're familiar with, could be really distressing for our patients with dementia, and of course our other patients as well. Yeah. So a lot of interaction between the emotional distress and the physical conditions that we try to keep, running in a homeostatic way, really, as nurse practitioners. Yeah. What do you feel the nurse practitioner can do in their practice to sort of set themselves up to deal with this? It looks like the pandemic's going to go on, or lockdowns are going to go on for a while yet. So we're learning some lessons in here. I hear telehealth as a solution. Any other things that you are implementing in your practice that are really helpful?
So I'd say we take care of ourselves as well.
Mm-hmm.
And that comes with the physical aspect of it, which means we have to make sure we have the correct, proper PPE.
Mm-hmm.
Hopefully that is available because we have to take care of ourselves. We cannot get sick because then who will take care of this patients that we are under our care. So I would say number one, make sure you are in proper PPE, N95 mask, for example. And I know there's a problem with supply, but we have been creative in like reusing and in our own way trying to decontaminate the mask every time after use. That's the one thing. That's the physical portion of it. The second is the emotional, psychological portion of it. It takes a toll on us. And this is speaking from the perspective of somebody in the community where we send our suspected COVID-19 patients to the hospital in the ICUs. How much I could only imagine how much emotional distress and burden is that for our colleagues in the ERs and the ICUs and the hospital. In the
Mm-hmm.
community level, we see that a lot too. We fear for our patients. One resident who becomes positive in an enclosed residential home with 6 residents in it could mean a disaster where everybody could get the virus and everybody is vulnerable. So there's a lot of psychological, emotional burden on those in the front lines. So what we've found, I personally have found, is to decompress every few days. I speak with a trusted friend and just sort of, let it out there. And this particular friend is not in healthcare, so he just doesn't have anything much to say, just listen. And I think that's what we need, just kind of get get it out there every once in a while with a
Yeah,
trusted person.
yeah, yeah,
Yeah.
yeah. I agree with you, Ron. Um, it helps us regain our perspective, fill our cup, and
Hmm.
be able to go forward with the hope that we all have. Clinicians are very hopeful people. We think
Right.
we can fix things, and we
Yeah.
usually do. So we need to restore that, I think, in ourselves for
Mhm.
sure. I had a question about. Uh, I don't know if it's helpful or not. Are you looking at PPE burn rate, or are your facilities using that CDC calculator to see how much you're going through and kind of predict what you need? I'm wondering if some of our members in parts of the country that are not hit as hard, as those of us in Detroit, you know, New York, California, they may have some PPE and they may want to get it to you. Just a thought.
That is a great idea.
Yeah,
Yeah.
maybe we should call on our members and say, hey, let's come together with a centralized way that we can, you know, distribute to our fellow members and help them out, because that's something that you just can't really imagine how worried providers are at bringing it home, because providers know they're in contact with a lot of patients, right? And
Right.
so you're worried about when you go home, you know.
So it's a community level of care. We're not very sophisticated as far as like allocation, and we play it by ear down here.
Mhm.
So that's really something that if we could do something like that would be very helpful.
Yeah, yeah. All right. I'm going to get to work on that one. A couple other things, Ron. I know that you're going into the residential care facilities or nursing home type facilities. How has that impacted your care? Of course, there are certain procedures that you're going through to
Mhm.
enter those facilities. There's doffing and donning that goes on. Are you seeing the COVID patients on specific wings? Are they in single isolated rooms, or how is that working?
So in the particular communities that I go to, we have, well, there's one facility that has allocated one wing for either COVID-19 positive or recovering patients slash residents. So they have done that in anticipation if they do have residents who either went to the hospital, come back, who was tested positive for COVID-19. Um, our clinic has some supply of PPE, gown, mask, and eye shield, face shield. So we are very judicious about using them because we tried to look around online, including Amazon,
Hmm.
and we couldn't find. It's like 3 months out before they can deliver. So we're very judicious about using those. So we've been using telehealth a lot unless we really have to see a particular patient slash resident. Or the other option then is to send them to the ER. And and our really standing protocol in home-based primary care is to avoid the ER hospital as much as we
Hmm.
could with these older adults. It's not really a place for them unless of course they really have to be there, like say for chest pains and other stuff that are more critical. So now that's taken that perspective where we now cannot just say send them to the ER because also um, we take it into account that we don't want to overload the ERs. So we try to see if we can help particular patient at home instead of just say go to the ER. So it's challenging because with telehealth you cannot listen to their heart and lungs. So now you just have to be a little bit more perceptive of whether this is something that needs to be sent out or the other way is to go see them. So
Hmm.
I've had to see a couple that, just not sure how they look like online. And so really had to take a listen to their heart and lungs and decide whether they need to go out or not. I had a particular patient who was older person and then had respiratory symptoms. And of course, we were thinking maybe this is COVID-19 and sent her out to the hospital. And then she tested positive. But then we tested those in that particular area where she was at and those that were in contact with her, including myself. We all tested negative. So,
Hmm.
and of course, these tests are not as accurate. There's probably 70, 80%, you know, to that. And so, but we're also thinking that maybe she got it when she was in the ER or, just waiting for a room. So there's all these questions that we have to maybe answer in some time in the future.
Exactly. We're learning as we go. as we're
We're
encountering
learning as
things that
we
we
go.
haven't encountered before. Do you find that in California, have you been able to have access to testing? So you said, it sounds like you are. It sounds like when you had that patient instance, you were able
Mhm.
to get all your staff and yourself tested.
So the public health locally is very on top of things. When we had that particular patient who tested positive in the hospital, they came to the facility and tested everyone that needed to be tested. Um, there is in our locals in the city where I'm at, there is an urgent care clinic that tests patients, and that's where I went to. I didn't go through the public health because I did go online and submitted like the questionnaire, and they said the answer was like you're not you don't need to be tested. But I wanted to make sure that I'm not bringing anything anywhere. So I went to the
Exactly.
urgent care, yeah, and I paid private pay for that. But there is some testing in the public health, local public health here has been very responsive.
Oh, that's very good.
Yeah.
Exactly. We have contact with so many people when we're giving healthcare. There's no social distancing
Hmm.
in giving healthcare, right? And doing
Yeah.
our exams. So we have to have the PPE. We have to decide when we have to have that close contact to
Hmm.
evaluate someone. And then we have to have the assurance that we have testing for our patients, ourselves, family members, so that we can make sure that we're not being the person carrying
Yeah.
COVID to the
And
next
there's
encounter.
there's the other challenge with using the PPE. This our older adults have some of them have hearing difficulties, and they tend to read your lips, and now they can't see it. And so, and then they also, I've had this patient who's like, "Who are you?" And I've been seeing this patient very often, but of course I'm all geared up, and they can't see me.
Right.
Uh, and so it's a challenge in that sense as well.
Yeah. Yeah.
Yeah.
And trying to communicate with just your eyes.
Mhm.
That's what
Yeah.
they can see.
Right.
It's they don't get to see your facial gestures and
Yeah.
all of that to
And
see
so
that
the
friendly face.
the hearing, the challenges with hearing, I've not been, I've sort of taken that for granted because I talk to them and they understand. They seem to understand me. They give me the answers that I think was appropriate. But now I realize that they were reading my lips because now this time they they just couldn't understand what I was talking about.
Yeah. Yeah.
Yeah.
Yeah. Another thing to that's new that we have to try and figure out how to manage. Yeah. Yeah.
Hmm.
Is there anything else that I've skipped over here as we talk about homebound care? Maybe just a couple of things for our members that are not in um, this position of providing homebound primary care. A little bit on the landscape of that. How do you see that rolling out as we return patients to the community from care in the hospital and do you see home-based primary care getting a little more attention now?
I think so. I read an article, and I don't remember it was for New York Times or about doctors in Italy who is saying that we need to be able to take care of our patients at home. That struck me as like this is very true. So we need to so home-based primary care or the capacity to take care of our patients at home is getting a lot of attention nationwide and possibly worldwide. And I'm very hopeful that this will put a spotlight on home-based primary care that we can grow. There's only about very few, about maybe 1,000 providers nationwide doing home-based primary care. And last I looked, there's about 10,000 patients that need it. So there's that big ratio that we need to deal with. So I'm hoping that with what's happening, home-based primary care, and not just the medical portion of it, but the nursing and the caregivers, we'll have some light, and so I'm really interested in policy related to this, because there's a lot of things that need to be done.
Yeah. And again, that may be a positive that comes out of all this, the attention that there is a lot of, if you will, burden placed on the family, but not the resources. And then when we have home-based primary care providers like yourself, you are shoring up that family. Yes, you're going in and doing the medical visits, but you're sort of case working. You're pulling together what is needed for that individual and family in their home. And then you're that reliable source that they can pick up the phone and call if they have a question.
Yeah. Well, we have started helping out with the homeless population in our area.
Oh, have
And
you?
yeah, and so there's the medical portion of it. They need the refills. They need to know if, they're doing the right thing medically. But I just realized how much the psychosocial aspect of their care needs to be addressed. Like they don't have transportation. They cannot pick up their medications, even if I refill it. There's a lot of those things that I feel just was brought into light because of what's happening.
Yes, very much so. And are those folks that you're seeing, are you seeing them with televisits, or are you going to the shelter areas, or?
So Governor Newsom, California, has this program to house the homeless, I guess for the period of the pandemic. So I've been seeing them, well, telehealth, but they're in the hotel rooms that's been allocated for them.
Yeah, and you think about food,
Mm-hmm.
how are they getting their food? They're not able to panhandle. People are not out on the streets. Um, so are you seeing some help with the restaurants? Are they doing any grab and goes or is there an organized effort for getting food to the homeless that are in these hotels now?
Yeah, so things like this can also bring out the best in most of us, right? So there's been a lot of volunteer work around, like making sure there's food for not only for the homeless people, but basically everybody who needs it. So the effort has been tremendous and very inspiring.
Yeah,
Yeah.
yeah. I agree. We're seeing a lot of restaurateurs step up. We're seeing just grassroots organization to make
Right.
sure that you know seniors who are on SNAP program, or any of those that we know about, are certainly getting um, food delivered to them. And of course the kids are getting their free lunches and
Mhm.
their uh, breakfasts and all of that stuff. That's all being delivered, so that's really good through the whole school system network here in Michigan anyway.
Mhm. The same here. I'm hearing of that too.
Well, as we kind of come to a close, Ron, I wanted to mention to our members an invitation from the Institute for Healthcare Improvement. They've began this rapid response network, and they're doing national nursing home huddles. These are starting on Monday, and the huddles are to bring together all the stakeholders who can improve care of our older adults in nursing homes and look at what can we do better to respond to this COVID crisis, and then also plan in the future. Also look at why are there disparities among those suffering the worst effects of COVID. So I think our members should be really interested in this, and I know you are. So I'm going to tell the URL where you can sign up. It's nhome rapid response .ihi.org. So I encourage all of our members to take a look at that. I know even if you don't work in the nursing home environment, you are sending patients there. If you're an acute care provider, if you're a home care provider, you're receiving patients after they've been rehabbed from the environment, and you have a lot of great ideas and definitely can be a big part of the solution to disparities in care that are happening there, and improvement of the care and protection of our patients, both in COVID and in regular flu season or any other kind of instance. Ron, any additional words of wisdom for our GAPNA members?
Well, I'd like to thank you for having me here, and wishing everybody staying safe and healthy. And thank you for being in the front lines and taking care of especially our older adult patients.
And thank you, Ron. Thanks for your time, and thank you for all your efforts. And of course, you're on the front lines and you're representing nurse practitioners so well, both in caring for people and in your policy work. So we thank you for that.
Thank you
Have a
very much.
great day.
You too. Thanks.